بسم الله الرحمن الرحيم. أهلا بكم طلاب وأطباء طب الفم والأسنان في International Online Dental Uses Congress في نسختي الأولى من اتحاد الجامعات العلمية لطب الأسنان وحديث التخرج والتابع ل EADS Egyptian Association of Dental Students، وهي الجهة العلمية الوحيدة الموثقة في مصر والتابعة للاتحاد العلمي فيما يحض الطالب وحديث التخرج داخل الجامعات المصرية. وهدفنا هو تطوير وتعليم طلاب الأسنان في جميع مجالات الأسنان، كما نهدف إلى تطوير الطلاب في أجزاء أخرى مثل السوفت سكيلز. ونحن متواجدين الآن في أكثر من 33 جامعة، ويتضمن المؤتمر أكثر من 100 دكتور من مصر وخارج مصر من الدول العربية والإفريقية المختلفة من كبار الدكاترة والأساتذة المتواجدين. وسوف تحصل على شهادة معتمدة بعد حضورك نسب الحضور المطلوبة للمؤتمر. وهناك سحوبات يومية تصل قيمتها المالية إلى 4000 جنيه مصريا، وإجمالي السحوبات في المؤتمر تصل إلى 50,000 جنيه مصريا. ونعلن عن الشراكة بيننا وبين دول لبنان، فلسطين، السودان، رواندا، قطر، السعودية، تونس، المغرب، تنزانيا. نتشرف بالإعلان عن البورد الرسمي للمؤتمر رئيس المؤتمر الأستاذ الدكتور عبد الفتاح صدقة، الرئيس الشرفي للمؤتمر الدكتور حاتم الجندي، السكرتير العام للمؤتمر الأستاذة الدكتورة هالة هزاع، اللجنة العلمية للمؤتمر الأستاذة الدكتورة عليا محروس، المشرف الأكاديمي الأستاذ الدكتور جايلان الجندي، الضيف الشرفي للمؤتمر الأستاذ الدكتور شذا حماد.
Good evening, everyone. I am very honored to be one of the speakers at the Egypt Association of Dental Students in EUDC. I would like to thank the entire organizing committee of this conference, and I would like to thank all the organizing committee of this congress. This group is founded for not-profit purposes, and it works with an international association in an official way, which is EADC, whose the only objective is to educate dental students on all levels. A very important notice I address to the dear students, and I will say to have the certificate at the end of this conference. I would advise you to answer obligatory to my two questions, deliver it to the organizing members. So, honorable assistants, allow me to present to you my conference entitled Dental Implant Placement in Posterior Maxilla. And before starting, this picture is not taken in Rome, Italy, but rather it corresponds to the Colosseum of Iljam, a city related to the governorate of Mahdia, located in the east of Tunisia. So we can begin our conference by saying the etiologies of the tooth extraction, as you know, are frequently related to tooth decay, periodontal disease, or trauma. But it's necessary to think of the prosthetic rehabilitation as soon as possible to avoid the phenomenon of resorption. So, several classifications of post-extraction resorption were established, such as the most known are the classification of Lukholm and Zarb, who noticed the variation, three-dimensional variation of the crest. And the second, the classification of Sieber, who identified three types of bone defect, as you see in this picture. Type 1 horizontal defect, type 2 vertical defect, and type 3 mixed defect. I would like to present a short review of implant and bone environment. As you see in this diapositive, the implant must be placed with respect of the biological way, and a distance of 2 millimeter is favorable to respect the position of the implant between uh, root canal. D'accord? And for vestibular palatal plane, a distance of 2 millimeter must be respected from the crest ridge, buccal and palatal vein. But we can be confronted with a crest and with an insufficient bone quantity, so we cannot put the implant at this moment, and we should pass by a pre-implant surgery like a block grafting in this way, or when we do the dental implant in the posterior maxilla, we should perform a maxillary sinus floor elevation, as you know, as you see in this picture. So, three type of management of this bone defect. We begin by block grafting, as you see in this photo, or GBR to increase the level of the bone, or a sinus floor elevation, which is the topic of our conference. So, what are the several indications of sinus floor elevation? We should present the Jensen's classification, who related the quantity of the bone under the maxillary sinus floor and the way of dental placement. And if we are in the class D, when the bone is around 1 or 3 millimeter, we should do a lateral sinus floor elevation with delayed implant, which is the topic of our conference. A short anatomical video review for the maxillary sinus floor, which is entitled A Trip Inside the Maxillary Sinus. This video was made by our team in anatomic laboratory, as you know. So the maxillary sinus floor is a cavity in the maxilla. It presents a pyramidal form with three walls, a roof, and a base. This we begin by this wall, and we see in this picture donc the canine fossa, the posterior superior wall, as you see in this video. It's related to the region of molar, and it presents the foramen of passing donc the artery and the nerve destinated to the innervation and vascularization of the molar. The superior wall, it presents the infraorbital canal, which contains the infraorbital artery and nerve. This canal ends with the infraorbital foramen situated in the facial wall of the maxilla, as you see here. The base of our cavity is the nasal, known as a nasal wall. And finally, the floor of this cavity, and which is related to the maxillary alveolar bone. And we can see in this picture the directly projecting of the tips or of the region of molar in this cavity. So the maxillary sinus is tapiced with a Schneideri membrane. It's a respiratory membrane, and it can present many walls who separate this cavity is where is known as septum, intrasinusal septum, as you see in the axial or horizontal or sagittal plane. This is a short review of the vascularization and innervation of the upper teeth, posterior alveolar, superior alveolar, artery and nerve. And finally, the AAA, 3A, the alveolar antral artery, which is anastomosis of the infraorbital and posterior superior alveolar artery. It can have three forms, and we will discuss this at the end of the conference. And after tooth loss, the bone under the maxillary sinus cavity will be decreased, as you know, after resorption, the phenomenon of the resorption. So this is the article which is published in Scholar Journal of Applied Medical Science. And we made radiological classification, as you see. Type 1, the tips are tangent to the maxillary sinus floor. Type 2, the most dangerous classification is this. The tips are projectly directly into the cavity. And type 3 is the safest type, and the root tips were situated distantly from the maxillary sinus floor. And the second molar was B, was the tooth, the most projectly tooth into the maxillary sinus floor. And we see often the candle burns at both ends. So the difficulties of dental placement in maxillary posterior maxilla, that are two difficulties. The first is the sinus pneumatization after tooth loss, and the bone resorption after the extraction of tooth. So, what the risk factors of maxillary sinus? We have first of all the alveolar antral artery 3A, the sinusal membrane, and the maxillary sinus septa. We begin by the alveolar antral artery, which is an anastomosis between the infraorbital artery and the posterior superior alveolar artery. And we made a classification into our department, and this artery can be presented in three ways or three forms. The inverted C, first of all, and this artery is extraosseous, as you see there in the cross sectional of the CPCT. The second way is that the artery is intrasinusal, and we will have the letter of C. And finally, a fully intraosseous situation, and we will see the letter of O. And if we assemblate the three ways, inverted C, O, and C, we will have the channel classification of the 3A. This is a case report done by me. We after releasing the flap, and you after performing the window of the bone window, and we see in this way the alveolar artery, which is situated in the middle of the window bone. And if we focus it on the internal wall of this window, we can see the groove of this artery. Maxillary sinus floor elevation after putting bios and sutures. In the literature, the prevalence of this artery is around 47 to 67%, and the detection of this artery is very easy if the diameter of this artery is superior to 2 millimeters. However, this is very important notice, its radiological absence doesn't exclude its clinical presence. In this case, the artery will have the caliber inferior to 2 millimeters. So, what's the tricks of this management of this artery? We can do the bone window translation, as you see in these pictures. We can move the osteotomy of this bone window forward and down, or up and back. Or we can modify the design of this window bone by performing a double window, as you see in this case report, to let the artery in the middle of the bone. We move to the maxillary sinus septa. As you see in this diapositive, we can have the septa in the axial, coronal, or sagittal way. This is a meta-analysis which presents a prevalence of around 30% of maxillary sinus with septa. And the location of this septa is near to the second premolar or second molar. Tricks: we can modify the design by doing two bone windows separately by the septa. Another obstacle is the sinusal membrane, as you see in this picture, is a very thin respiratory mucosa that lines the sinus cavity, and the most difficulty in this management is the great risk of perforation. As you see in this video, the artery is there, and the membrane integrity was checked by evaluating its respiratory movements. As you see, we require to the patient to breathe, and if there is no perforation, we will see this kind of movements. This, voila. If we have perforation, and due to the high regeneration potential, the perforation management can be doing by sutures, PRF, and collagenous membrane. We move to clinical illustrations. Case number one. This is my first maxillary science floor elevation in the outpatient department. It was a doctor. The retroalveolar radiographs showed donc, a quantity of bone which is insufficient of dental placement in this way. And the remark here is this opacity into the maxillary sinus. After doing CBCT, we have a RBH. The quantity of bone below the maxillary sinus floor was approximately of 1 millimeter. We are in the class D of Johnson classification, so we must do maxillary sinus floor elevation with delayed implant. And for this opacity, it was an osteoma, intrasinusal osteoma, okay, which is a pseudo tumor, and it's very rare to present this osteoma into the maxillary sinus floor. Local anesthesia was carried, crystal incision, intracircular incision regarding tooth 17, and releasing incision distal to tooth 15, and the excision of the lateral window along with a part of the osteoma that impeded on it was performed using piezoelectric inserts. And the remaining part of the osteoma was kept in place. Then a collagenous membrane was placed beneath the sinus membrane. Why? To reinforce it and prevent a possible leak of bone particles into the antrum. The maxillary sinus cavity was condensed by xenograft to fill the antral cavity, and the seat was covered by a collagenous membrane. Then we finish it by doing stitches, and we move from this situation to this situation, and we can see the increasing of the bone below the maxillary sinus cavity. And after 6 months, we put the implant, and after 2 months, the crown was in place. The article was published in Impacted Indexed Review, as you see here, and is called the lateral maxillary sinus floor elevation in the presence of the sinus osteoma, a case report. I can give you a link after this conference to read tranquilly this article. This is my friend Mu'taz. We did the surgery together, and we moved to the second case. It's related to a 50-year-old female patient, and we do the rehabilitation of the maxilla from 14 to 16, and the OPG showed a more and less insufficient LBH. So we require the patient to do CBCT. Regarding 14, we will do the tent pole technique, and regarding 15-16, we will do a sinus lift or maxillary sinus floor elevation. After local anesthesia, crystal incision and transcircular incision regarding tooth 13, 12, and releasing incision medial to tooth 12. We performed the bone window, and the excision of the lateral window was performed using piezoelectric inserts. Kif, the same thing. We should check the integrity of this membrane. Donc, there is no perforation, and the membrane integrity was checked by evaluating its respiratory movements. As you see there. After that, xenograft was condensed within the cavity, and for the tent pole technique, it requires the principle of this technique is to screwed a partially screwed osteosynthesis screws serve as a support of the GBR. 2 or 3 screws can be loaded to perform this tent pole technique, and then we will do our GBR. Collagenous membrane was performed to cover all the set, and then 2 apical matrices sutures were performed to decrease the excessive flap tension, as you see in this photo, and the tension there was translated from the crystal incision to a more apical level, as you can see in this diapositive. And now we are respecting the biology. After 6 months, we can notice the bone gain, and for the medial side, we will move to this situation on the right, on the left, to this situation on the right, and we will have approximately horizontal bone gain of 3 millimeter after 6 months. And for the sinus lift, we want approximately 4 millimeter of bone gain, vertical bone gain. We move to the third case. A 55-year-old male patient is required in our department to do a rehabilitation of the posterior maxilla from the 13 to 17, and preserved available prosthetic space was noticed. The OPG showed a vertical defect due to the pneumatization of the sinus and resorption of the alveolar bone. The decision was performed like just said. Donc, we will regarding to the horizontal defect, we will do a bone grafting, harvesting from the symphysis, and regarding vertical defect, we will do a sinus lift, as you see in these images. For implant placement, and regarding tooth 15-16, we will do sinus lift, and regarding 13-14, we will do a block grafting, harvesting from the symphysis. While releasing the Schneiderian membrane, we must reach the nasal wall of the maxillary sinus. It's a very important thing to respect this protocol, and otherwise the palatal side would be left untouched. sorry. And this in this picture, IPRF was injected to optimize the processes of healing. This is the sinusal membrane. This is the rotation of the bone window. And finally, we put two PRF membrane into the maxillary sinus. Why? Well, because there are two reasons. The first is to manage it microscopic perforations, and the second is to optimize healing because PRF contains many growth factors. And for the mesial site, we will do cortical stimulation to enhance vascularization of the graft. The block grafting was separated into two halves. The first was screwed into the mesial side, and the second was be mixed with the xenograft to fill the maxillary sinus cavity. GBR was performed. We put two membranes to cover the entire site, and the same we put it to pre-RF membrane to optimize the healing process. And sutures are there. This is a remark that the suture nodes must be deported away from the incision line for more for respect the biology and to increase the process of healing. This is the line joining the sutures nodes. Another view of this fact. 6 months, another CBCT was performed, and we showed this horizontal gain and vertical gain. This OPG was performed after 6 months. The four implants were placed, and we can see in the posterior side the vertical gain with the maxillary sinus lift, and the treatment plane was achieved successfully. After the implant place, we will think to increase the quantity of keratinized gingiva. So we performed a roll flap technique, as you see in this photo. This is the connective tissue. We put the healing abutment and we enroll this connective tissue to increase exactly the buccal side of keratinized gingiva. This is soft tissue management. And we do a stitched, and we put the healing abutment over the multi-unit abutment. And after healing, we moved from this picture to this side with this beautiful bounded profile of gingiva. And this is the final case report. This patient was referred to our department to placement of prosthetic in the site of 16 and 17. The CBCT showed an insufficient bone quantity, and this we have 6 millimeter. So we can do an alternative or maxillary sinus floor because the patient refused this technique, and we put a short implant in this way. This is the clinical depth, and the short implant was put in place. So take home message: the lateral maxillary sinus floor elevation must be properly indicated, in-depth clinical examination with a complete radiological assessment such as OPG and systematically CBCT. The risk factors of maxillary sinus cavity is the sinusal septa, the sinusal membrane thickness, the 3A antral artery, alveolar artery, the anatomical variation such as the osteoma, and the sinus permeability. And it's very important to say that surgery, the using of PRF, and the good choice of the bone grafting materials can lead to a good prognosis of our surgery. And thank you for your attention. So I repeat that it's a very important notice I address to dear students to answer obligatory to my two questions delivered in the organizing members. Thank you. Thank you for your attention. I invite Dr. Ala or Dr. Noor to join us. And if there is any questions, you can put it or send it to my mail. It's written in this diapositive, dr.tlili.mohamed@gmail.com.